documentation checks. Okay, thanks. So anyone who are interested in about the data set, especially we have 18 centers from 10 institute data set in this challenge. So you are if you are interested in this challenge, you can join this one during the MICAI conference. Also the last one is STAYCOM. So SIG-Cardiac is collaborated with STAYCOM. STAYCOM is very famous workshop in the MICAI, and it have 15 years history. So if you have manuscripts about these topics, you can submit your manuscript to STAYCOM. Now let's turn to our today's seminar. Before we started, I have three things to mention. The first one is the meeting is being recorded. So Xintao, could you help me to record the meeting? The
Okay,
second
I
one
have.
is okay, thank you. The second one is to please keep your microphone muted during the talk. If you have any question, you can type it in the chat room box. We will have a Q&A session at the end. So today we are going to talk about a very exciting topic about how to use AI technology to help diagnosis and treat heart disease. So we are very happy to have Professor Xiaowei Xu with us today. And Professor Xu is a leading expert in this area. She leads the AI and 3D technology lab for heart disease at Guangdong Provincial People's Hospital in China. She is also very well-known Humboldt Research Fellow in Germany. She has published over 14 research papers and lead many important research projects, such as National Nature Science Foundation of China and Guangdong Guangdong Special Support Program for High-Level Young Talent. So we are so lucky to have him to share his knowledge and experience with us. Now let's give a very welcome to Professor Xu to have his speech today. Professor.
Yeah, I can hear you. Thank you for the invitation and
Yes.
introduction. Can you hear me?
I can hear you. The stage is yours.
Okay, I will share my screen. What am I going to share? Only one person can share one time. So maybe you need to
Okay.
quit the sharing, maybe. Yeah.
Okay. Wait.
Or maybe replace current share.
Okay. Stop my share. Professor, now you can share your screen.
Okay, can you
Okay.
see my
I can
screen?
see the
Okay.
screen.
So hello everyone, thank you for being here. I think it's dinner time in China, or it's quite early in the US, I think. Anyway, so today I would like to share my work about artificial intelligence in diagnosis and treatment of cardiovascular diseases. So in my talk, I would like to give three aspects. First, I will give a brief background of cardiovascular diseases. Then I will talk about our AI research in cardiovascular diseases. And last, I will share some interesting experience doing AI in hospitals. I think it's quite lucid in the research field. So first, background of cardiovascular diseases. I think you all know cardiovascular diseases. It's a group of blood and heart disorders that can lead to heart attack and stroke. It is the uh, number one cause of death worldwide, and 1 out of 3 deaths worldwide are due to cardiovascular disease, and 3 out of 4 deaths from cardiovascular disease occur in low and middle income countries. So the mortality is quite high, and it's not the number one. Basically, it's the most serious disease in the world. First, I would like to introduce some very interesting background of cardiovascular diseases. Basically, there are two kinds of cardiovascular diseases. First is congenital structure problems. For a gene cell, it will the heart structure will form in about 35 days from a gene fail. And you can see here, I think all of you may be quite familiar with the structure of the heart. But I will introduce a bit here. Basically, it has 4 chambers, right atrium, left ventricle, and the right ventricle. And there are several vessels that are connected to the 4 chambers. Superior vena cava, inferior vena cava that are connected to the right atrium, and pulmonary artery, which are connected to the right ventricle. Pulmonary veins are connected to the left atrium, and the aorta are connected to the left ventricle. And this picture, in this right picture, shows the heart disease, congenital heart disease, which is with very structural variations compared with the normal heart. You can see here they are very narrow. The beginning part of the pulmonary artery is narrow, and sometimes it is even blocked or absent. It means there are no connections between the pulmonary artery and the right ventricle, and there's a hole between the left ventricle and the right ventricle. These are all caused by the congenital cases. And the second, also the major part of congenital heart disease is due to long-term working. And you can see the right picture that there are many vessels in our body. And I have very interesting question for you. How many times did you think that the heart will beat during our lifetime? And how long is all the vessels in our body? You can have a guess, give you maybe 10 seconds. Okay, how can you say how to type the
So I think everyone can unmute your
just a guess,
microphone.
yeah. Just a guess, no. Okay, say something.
Maybe 1 billion times. Is that
1
right?
billion. Let's give you the answer. Almost right, yeah. 3 billion times beat for an adult with about 18 years old. Yeah, and 69 kilometers. Yeah. So our blood system and heart will work very hard during our lifetime. So sometimes most of the time, this will introduce some problems. And we can see some examples here. The vessels will become less elastic or sinking or blocked, as shown here. And sometimes the valves, there are many valves in the heart and even in the vessels to keep the blood flow in one direction. And after long time working, the valves cannot block the blood perfectly. So it will also introduce some problems. And this picture here shows a very common cardiovascular disease due to the long-term working. For example, this is a cover, superior vena cava. After long time working, the vessel is less elastic and hypertension happens. for general, of course, of course, due to this situation also happened for other methods. And this one, and in the right upper corner, the thinking corollary methods. These methods are supplied more material and nutrition to the heart. The right one, the right upper one. And if the myocardium or muscles of the heart cannot receive oxygen and nutrition enough, then the heart will have some problem and cannot beat efficiently, and this is called coronary heart disease. And in the heart, there are 4 valves as shown here: the aortic valve, pulmonary valve, and the mitral valve, and tricuspid valve. There are 4 important valves in the heart, and the valves cannot block the blood perfectly, while valvular heart disease happens. And sometimes there are also some problem with the myocardium, the heart muscles. Usually there may be the muscle between the left ventricle and the right ventricle is thickened, which will reduce the volume of the left ventricle. This will called hypertrophic cardiomyopathy. So let's have a look at our research in cardiovascular disease diagnosis and treatment. First, briefly introduced to our institute. We are the top 3 cardiovascular center in China, and there are more than 21K and 3K interventional operation and surgical operation annually. And we are the only one WHO, World Health Organization Cooperation Center for research and training in the field of cardiovascular disease in China. And this is the front door of our lab. And there are Chinese characters, and you can see here the name of our lab is Laboratory of Artificial Intelligence and 3 Technologies for Cardiovascular Diseases. And in our lab, there are mainly 4 aspects for cardiovascular diseases, with a special focus of AI for cardiovascular diseases. The 4 aspects includes automatic segmentation, automatic diagnosis, automatic prognosis, and automatic navigation. In automatic segmentation, the main task is to detect the anatomical structures. As shown here, we can use different colors of the heart structures. I think you all know this well. And this second part is automatic diagnosis, is to use AI to perform the classification of diseases. The third part is automatic prognosis. Prognosis is to predict the future of the patient, whether the patient will recover from the disease or whether the situation of the patient will become worse. So depending on the prediction result of the patient, we can make some specific treatment. For example, we can choose the right treatment for this patient. And the last part, automatic navigation, we mainly focus on surgical planning. For example, as the picture here shows, we can use 3D printing to print the heart of the patient out, and we can perform some simulation on the printed heart model. And so here, the patient is to use some surgical tools to perform surgery on the 3D printed model. And we can also use some VR, virtual reality techniques to view the 3D heart model in the VR world. And in this way, we can check the anatomical structures of patients more precisely and efficiently. And in the following slides, I will select 1 to 2 cases from the 4 aspects for discussion. First, automatic segmentation of type A aortic dissection. In a normal heart, especially in a normal aorta, as you hear the red one, the red vessels are aorta. And in some parts, we can have a more detailed view of the vessel structures of aorta. Basically, there are 3 layers. the intima, media, and adventitia, the 3 layers. Anyway, you can just regard there are 3 layers, and sometimes the blood in the blood there's some hole in the intima or in the inner layer of the aorta, and the blood can flow into the second layer. And this can this hole and the region of blood in the second layer will increase during as the disease developed. And after maybe several years or maybe or more than 10 years, the area in the second layer grows very large, as shown here. Sorry. The blue or the purple arrow is the arrow in the second layer. It becomes very large. But this was the vessel, the blood in the second layer or in the fourth lumen cannot provide any blood to the other organs or anatomy structures. And let's have a more detailed or view of the anatomy structures of type A aortic dissection. This here is the CT rendered CT images. The next one, and this one is anatomy the segmentation result, segmentation illustration of the type A aortic dissection case. The red part is the true lumen or the original aorta, full with blood that can fed to organs and other anatomy structures with oxygenated blood. And the gray one is the fourth lumen or the blood full in the second layer. And there's tear between the true lumen and the fourth lumen, and the blood will flow into the fourth lumen from the true lumen. And you can see the detailed view of the tear and the fourth lumen and true lumen, the tear in the CT images, and this is the sagittal plan of the tear. This is quite dangerous, I have to say. It will cause aortic rupture or explosion. At the end of the disease, the patient will, the blood of the patient will explode, which means there's bone. And maybe in less than 3 minutes, the patient will die. So it's a very serious disease. And surgery treatment is the main treatment method for such kind of patient. I would like to show here several cases, several surgical strategies for different kinds of patients. So basically, the surgeons need artificial blood vessels and stent to reduce the error of the fourth lumen and restore the correct flow of the blood. But before surgery, the surgeon need to have a vivid understanding of the anatomy structures of the patient heart. As shown as in this picture, they need to how the structure of the fourth lumen is and how is there any organs or vessels that are connected to the fourth lumen. And with this, they need to do some further evaluation as shown here. First, location of tails. They need to the precise location of the tails between the fourth lumen and true lumen. Second, they need to identify the involved vessels. As shown here, we can see this vessel. This orange arrow corresponds to the fourth lumen. There are many fourth lumen here. And sometimes the fourth lumen will the arrow of fourth lumen will increase. And sometimes this vessel the vessel A will be infected by the fourth lumen. In this way, the blood flow in vessel A is affected, and the amount of the vessels will be reduced, which will have some impact on the function of the connected vessels or organs. And vessel B is not influenced by the fourth lumen. They are totally connected to the true lumen. And C is less affected by the fourth lumen compared with the vessel A. So we need to evaluate how the connected branch vessels are involved by the fourth lumen. And the third one is the true lumen collapse. As shown here, we can have a slice in this part, and we got this picture here. So in this slice, we can see the true lumen and fourth lumen. If the true lumen, usually if the true lumen, the error of the true lumen is larger than that of the fourth lumen, we can say that the true lumen is collapsed, or called true lumen collapse, which means the function of the true lumen is seriously affected by the fourth lumen, which can be regarded as a very serious condition for the disease. And the problem is the current method only performs segmentation, and they didn't consider the clinical practice much. So we would like to perform the segmentation first, and then we will perform the evaluation of the three aspects here, or three features here. And we would like to explore whether the segmentation results, the general segmentation metrics, have a good connection with the features, with the real clinical features. Basically, we would like to know that whether a good segmentation results leads to a good feature extraction result for clinical problems. So we connect a data set which includes 120 patients, and we annotated 34 categories as shown here. The bounds are also annotated. And we propose a method as shown here, which is quite simple. I think it's ULAT. It's similar to ULAT, and we add some domain logic here. First, we introduce two decoders as shown here. The first output is general segmentation result, and the second decoder is to focus on boundaries and the tail position, because tail position is quite critical in this task. So we design a specific decoder for the tail and boundary segmentation task. And between the two decoders, we also introduce a way to somehow fed the boundary information and tail information into this decoder. This decoder is specific for general segmentation tasks. So there are two strategies to enhance the segmentation task for this particular task. And this is the segmentation results. And we can see that for some cases, both our method and other method cannot perform well. And yeah, and we are particularly interested in whether the good segmentation performance with high dice score can lead to good feature extraction results. So the three fingers here correspond to the three features discussed in the previous slides. In the x-axis is dice score, and y-axis is three features, the detection performance of the three features. First, we can see that our method with a special focus on the boundary and the tail position achieved the best score, best best DAS score and the best detection accuracy on both of the three features. And we can also know some interesting phenomena here. And the conclusion is segmentation accuracy has loose correlation with features. They are not obscenely correlated, but has very loose correlation. You can see here in this one. Okay, I need to. Okay. You can see here the NN former, NN ULAT 2D and 3D UXLAT. The three has obtained almost the same TLC feature extraction accuracy, but their corresponding DAS score varies a lot, maybe from 43 to 41. The score, the DAS score increased. The 3D UX net has achieved a much higher DAS score than ULAT, but obtained almost the same TLC feature extraction rate. Here, the situation is even more worse, as shown here. There are several methods, as shown here. There may be 6 methods in this finger. The 6th method achieved almost the same LOT feature extraction accuracy, but their DAS score also varies a lot. But basically, we can see still the trend as shown here. We can just say the usually the higher segmentation accuracy lead to a better feature extraction rate with a high possibility, but this is not absolute, right? I think the main reason is that the features or the clinical features of the surgeons or physicians they care about is determined by some specific areas. They don't care about the DAS score that much. They just focus on some specific areas that are highly correlated with the disease, but not all the anatomy structures are of the equal importance. So maybe in the future we need to perform some more domain-specific or disease-specific segmentation model to pay more attention to the regions that are important to the disease. Second, automatic diagnosis of congenital heart disease. This picture shows a normal heart structure, and the right one are 3 congenital heart diseases. But then in this one, the patented ductus arterial cells. In this disease, there are the vessel between the pulmonary artery and the aorta. And in this one, the connections between, in the normal case, the pulmonary artery is connected to the right ventricle, and the aorta is connected to the left ventricle. While in this case, the aorta is connected to the right ventricle, and the pulmonary artery is connected to the left ventricle. So their connections is changed, which also introduce serious problems. And the last one is a more serious condition. There's a hole between the left ventricle and the right ventricle. The initial part of the pulmonary artery is quite narrow, and the right entry is with a very large volume. So it's quite complex for radiologists to perform the efficient and accurate diagnosis of congenital heart diseases. So this picture here shows our AI system for diagnosis of congenital heart diseases. First, our ROI, regional interest extraction network, and then we perform whole heart and great vessel segmentation. I think you all know this very well. And finally, the only difference is that based on the segmentation result, we perform feature-based automatic diagnosis, as shown here. We used more than 1,000 manually segmented training images for the training of regional interest extraction network and Huazhong and Guangdong segmentation network. And finally, we used more than 2,000 test images to perform the diagnosis. Actually, there are more than 13 subtypes of congenital heart disease, and we only consider the most common 17 types for our research. You may notice there are some golden diagnoses. So in clinical practice, we need to define a golden standard because our method need to compare with the radiologist expert. So we cannot just use the diagnosis of expert radiologist as a golden standard, as a ground truth for comparison. We need some more golden standard to make the label. So we used CT images of the patient, of course, and we use the operative report, which is a summary report of the patient after surgery. So the surgeons can observe the anatomic structures of the heart, of the patient's heart. They can see it. They can they can physically see it or maybe touch it. So the report can give some insights or whether the disease exists or not. And finally, we have the discharge summaries of the patients, which is a report given to the patients after their discharge, after they leave the hospitals. And finally, we list several experts to review all the reports and make the final classification or diagnosis for the patient. So in this way, we can create a relatively more trustful or maybe more real result for the classification and the comparison with radiologists. And finally, we got 2,438 test images with golden diagnosis. This is the detailed framework of AI system. I have to say there are not much technical novelties in this framework. We just basically used 3D ULAT as shown here to perform some ensemble and get regional interest, and then Huazhong and Guangdong segmentation. We use more 3D ULAT to obtain the segmentation result of blood pool and their boundaries, and all the 10 anatomic structures and some other 7 or 6 anatomic structures. Anyway, there are 5 tasks in Huazhong and Guangdong segmentation. And you can see here the initial 128 or initial 64 corresponding. We use some, okay, there are 6 categories for such kind of task. We just add the initial part, as shown here, initial part of aorta and pulmonary artery, because the initial part of aorta and pulmonary artery played an important role in the following feature extraction tasks. And finally, we make some segmentation optimization with this segmentation result. We then perform some feature extraction tasks. We need to consider several features as shown here: connection features, shape features, position features, and some other features. Based on these features, we can perform the diagnosis. And I think it's quite new for you to know to know more about the feature extraction and rule-based diagnosis. So this table here shows all the rules for diagnosis. There are several disease groups. In each disease group, these diseases are kind of consider the same features as shown here. We need to connect. We need to for disease we need to consider the connection. COM indicates connection between left ventricle and the right ventricle, and other features. And despite connection features, we need to, a more common feature is the whether the vessel is narrowed or not. For example, the ratio here, the ratio PA to aorta, the ratio of the number of pixels of aorta to pulmonary artery within the inner part of great vessels. This can be used to determine whether the initial part of the pulmonary artery is narrowed or not. And other ratio features worked in the same way. So, and N island, the third popular one is N islands, as we see. Sometimes there are two superior vena cava, there are two SVCs. So we need to consider whether how many islands of the SVC. So basically, there are three commonly used features to determine the diagnosis. Let's have an illustration here. So you can see here that the airway, left ventricle and the right ventricle are not connected. So this feature equals 0. And if they are, this feature will equals to 1. And the right picture shows the feature of ratio, or to determine whether the vessel is narrowed or not. We see in the left one, we can see the diameter of aorta and pulmonary artery, and using this for this feature, the result is 1.22, and this one is 0.34. And if they are less than 1, if this feature is less than 1, we consider that there is this narrow or pulmonary artery. So let's have a look at the result. This is segmentation result. And for several subtypes of the congenital heart disease. We can see that for almost all the cases, the segmentation for AI. Okay, the left one is the ground truth, and the right one is the segmentation result by our AI system. So we can see that for almost all the cases, our AI system can achieve a comparable segmentation result with the ground truth. But for some detailed vessels or some thin vessels, as shown the myocardium, and some thin vessels that show here, AI system can cause some problems. And there are more segmentation results. Roughly the major part can correctly identify, but for some small anatomy structures, AI cannot effectively and accurately identify the part. So let's have a look at, okay, yeah. During the segmentation, we found that for each part, for example, the aorta and pulmonary veins, there are a lot of connection between the aorta and the pulmonary artery with other anatomies structures, like the left ventricle, right ventricle, superior vena cava. And we need to correctly identify the aorta and the pulmonary artery and get the clear or correct boundary between them with other anatomy structures. So we use some kind of graph-based optimization to refine the segmentation result. Basically, we just use some traditional machine learning method to get the skeleton of the vessels corresponding to the red line here. The skeleton or aorta and pulmonary artery, and we can use some graph-based analysis to extract each part of aorta and pulmonary artery. For example, as shown here, we can identify the main part, the PA trunk, the initial part of pulmonary artery, and the left part, the right part of the pulmonary artery, and the right part of the pulmonary artery. This is the final diagnosis performance. The green bar corresponds to our AI system. The yellow one corresponds to junior radiologists, and the orange one corresponds to the combination of junior radiologists and senior radiologists. This is also the clinical routine. Usually for clinical practice, the junior radiologist will write the report and the senior radiologist will check the result of the report. So roughly our method is better or comparable with that of the junior radiologist, but much worse than that of the compilation of junior radiologists and senior radiologists. So, there are not all abstraction during the research, and our method just a very initial taste of using AI for AI diagnosis. But basically, we have showed that AI has its potential for the diagnosis of congenital heart disease, but there are a lot of things that we need to do. This part shows the confusion matrix of our AI method, and you can notice there are many errors. So let's have more detailed analysis of the diagnosis errors. This case here shows the diagnosis errors introduced by connection between left ventricle and the right ventricle, these features. So you can see here, we just ignore or the connection between the left ventricle and the right ventricle is ignored here because it's very thin. So in our method, we cannot detect such kind of thin connections correctly. And in this part, there is no connection between the left ventricle and the right ventricle. The problem is that we recognize the initial part of aorta as left ventricle or right ventricle. So this part should be the aorta, but not the left ventricle. So, but due to this kind of segmentation errors, there exists a connection between the left ventricle and the right ventricle, which introduces the error, the feature extraction error. And this one is introduced by the ratio of of pulmonary artery to aorta. In this part, the ratio is less than 1. So we diagnose at 12, which indicates there is an error, but actually there's no error. So this kind of error gives us some ideas that the threshold of 1, the ratio equals 1. The threshold of 1 is not that correct to identify whether vessel is narrowed or not. But we cannot change the clinical practice right now, and we need more collaborations between AI and the clinical practice. So second, okay, maybe due to time limit, I will just keep this simple. Okay, the second part is automatic diagnosis of patent foramen ova. Pattern foramen ova indicates there is a hole between the right atrium and the left atrium, as shown here. And we can use ultrasound or echocardiography to identify or diagnose this disease. We can insert small bubbles into the heart, and we can to the right heart system here. And in the hole between the right atrium and left atrium, the microbubbles will also exist in this part. And with this formula, we can the pattern foramen ova can be diagnosed. And let's watch a very short video to illustrate the process. This is used to inject bubbles, microbubbles into the heart using a T-shaped injector. This process is to create microbubbles. And then we can insert the microbubbles to the blood system of the patient. The microbubble will first show in the right heart system, as shown in this part. The microbubbles. This is for microbubbles. And then if there are microbubbles shown in the left part, left heart system, it indicates the existence of the patient, of the disease. And in clinical practice, the physicians need to determine the amount of bubbles in the left ventricle and divide it into 3 stages: the mild, medium, and severe. During the examination, the patient need to perform 2 movements: rest and Valsalva maneuver. Valsalva maneuver means the patient needs to hold their breath. This can introduce the pressure in the right heart system and increase the number of bubbles that will flow in from the right part to the left part of the heart. So I will keep this very brief. Generally, we perform segmentation first, and then we extract the error and the mean intensity in each error, as shown here. And finally, we extract the intensity in each heartbeat. And finally, we can get the figure here. The numbers, the bubbles, the number of bubbles in the left ventricle, and in each heartbeat. Generally, this one is the most serious one because the bubbles increase a lot and then drop to the normal case. This is the serious one, and this one is this one indicates there is a hole in the pulmonary artery and pulmonary veins in the heart, which is another kind of disease, but not the PFO. And this one, the third one, indicates there's no PFO, and this one is a medium late or mild case. And this is the final diagnosis performance. This is a very initial trial, maybe. And you can see the 2 fingers correspond to the 2 states of the patient in the rest state or in the Valsalva maneuver state. And you can see that the proper accuracy is quite low, actually, even using AI. And we are still working on this project to find a more proper way to make the right diagnosis. Third part, pulmonary vein automatic prognosis or pulmonary vein atresia. The right picture shows the anatomy structures of the patient with pulmonary vein atresia. Oh, sorry, of total anomalous pulmonary vein circulation. This is disease. And usually heart surgery is needed for such kind of patient. And one of the main factors that affected the surgery is where pulmonary vein atresia happen. As shown here, pulmonary vein atresia generally means the block of the pulmonary veins, which is a very serious prognostic event. If there is this pulmonary vein atresia, the patient after surgery will die with a percentage of 17 to 18%, with a possibility of 17 to 18%. So it's quite dangerous. And the surgeons need to consider this a lot before surgery. So we perform very simple and initial trial on this interesting and dangerous event. We connect multimodal data as shown here, the CT images and some selected clinical features. The connected features are shown here. There's some report from about blood and other fundamental gender, some clinical features anyway. And we trained a classification network whether the pulmonary vein atresia happens or not. We use this CT images to train a classification network and use the last layer, the 512 values as the hidden features or extracted from the CT images. And these features, these 512 features are combined with the selected clinical features to fed into a FC layer to make the final prediction. And this is the result. You can see that the combination of data and clinical data and images achieves the best performance. Even the CT images, the CT images based approach can obtain some positive result, which indicates that the CT images also provide some information to the final prognosis. And we also checked the errors that are highly connected to the final prognosis or activated errors in the CT images. We can see that they are roughly focused on the non-error, but there are some cases that are also located in some black errors, which is quite strange to us. I have to say that the patient, the surgeons or the physicians are quite interested in the activity errors for them, so they may find some common structures that are activated for the patients, and which can give them insights for the further analysis for this kind of disease. But now we didn't find any valuable information from activation errors, which also needs some further investigation. And okay, finally, the automatic navigation. Basically, in this part, we focus on the surgical planning. In the current clinical practice, surgeons need to image the structure of the heart structure of the patient from CT images and ultrasound videos, and they can create a patient's heart model in their mind, and then they will perform, with this knowledge, they will perform the surgery. So it requires extensive experience and time for the surgeons. So we create our own VR system to help surgeons to perform surgical planning. The VR system is shown here. There are many Chinese characters here. Here it means the virtual reality for diagnosis and treatment of structural heart disease. And if you you wear or wear assistant or wear operators or something or glasses, you will see the word as shown here, and you will also see the 3D VR model, of course, and you can see also the two VR operator. And in the real world, you will also hold your two hands will also hold two VR operators to communicate or operate in the VR world. And with this VR system, we have performed several clinical applications. This one is for tumor resection in left ventricular. You can see the left object is a tumor. And we need to confirm whether the tumor can be held out from the aorta. Okay, let's watch it again. The left mass is a tumor, and the red one is the aorta, the beginning part of the aorta. We need to make sure whether it can be pulled out from the aorta. And this has been reported by some media in China. Another very interesting clinical application is for complex congenital heart disease. First, the patient is with pulmonary atresia with VSD. The next one is normal heart structure, and the right one shows the pulmonary atresia with VSD. Pulmonary atresia means there is a narrow or block in the initial part of pulmonary artery, and that hole between left ventricle and the right ventricle. And the patient also suffers from some anomalous vessels, as shown here, anomalous vessels. There are many anomalous vessels for the patient. They can be very thin and long. This red CT image shows these anomalous vessels. They can be very long and thin, and it's very hard for the surgeon to identify these vessels. Sometimes the surgeon needs to cut or block some vessels, some kind of vessels. But if such kind of anomalous vessels exist, this situation becomes more challenging for surgeons to make a right decision. And what we do is to show the patient anatomy structures when they are performed surgery, as shown here. During surgery, the surgeon wear mixed reality glasses. They wear mixed glasses so they can perform the surgery, and they can also see the patient's heart structures in the through the mixed reality glasses. The last interesting clinical application is the hypertrophic or cardiomyopathy. This picture here shows the heart structure of hypertrophic cardiomyopathy. Basically, the myocardium between the left ventricle and the right ventricle is thickened, which reduce the volume of the left ventricle, and at the same time, the beginning of the aorta is almost blocked. You know, with the motion of the heart, the blood in the left ventricle needs to be pumped out to the aorta. But now the beginning part of the aorta is almost blocked, which will affect the function of the heart. And this disease is also a very dangerous one, and it can be a very sudden condition. It is the main cause of sudden death under 35 years old. And the picture here shows a football player is died suddenly when he played football. And this picture here shows why this happened. Usually, we have some in the heart. There are some electrical signals to let the heart beat in its normal manner. And the ECG signal need to pass from the myocardium to pass electrical signals to all the part of the heart. But with the thinking of myocardium shown here, the flow of the ECG signals are somehow changed. And in some extreme cases, for example, for some runners in marathon, the influence of the ECG signals flow can cause sudden death. So the problem of hypertrophic cardiomyopathy is that during surgery, the surgeon need to identify the sinking myocardium and then they need to remove the sinking myocardium as shown here. And we would like to use AI to perform automatic segmentation of the sinking myocardium. And in this way, the surgeons can get a vivid understanding of the removed part of the myocardium and finally help them perform a very successful surgery. So we connect a data set of 15 patients and make a mixed label that's shown here. And for the sinking myocardium label, we have a very strict label rule that's shown here. The sinking myocardium must 5 millimeter below aortic ring, shown here. Anyway, there are many position requirements for the sinking myocardium. So as we mentioned that the surgeon need to identify the sinking myocardium with very strict rule, with very strict rule. For example, the relative position with other anatomy structures to let them make the right decision. So with this motivation, we performed a two-stage multitask segmentation as shown here. Basically, the core stage, the first part of the network is to extract the myocardium and ventricular or ventricle segmentation. And then we fuse this information with the original CT images to a fine stage. And during the fine stage, the position of ventricle, left ventricle, right ventricle, and myocardium, this kind of structure information into the network. And in this way, the network know not only the CT images, but also the positions of structures of myocardium and left ventricle, right ventricle. In this way, the network can perform better than just than the normal way. We can call this some kind of domain integration. And this is the final segmentation result. We can see that our method is a little better, at least for between the existing method. And we further perform some boundary analysis. For example, we calculate that 3 dimensions, length, width, and depth of the sinking myocardium to show that our method is more close to the ground truth. And finally, we perform a real-world application as shown here. With the segmentation result shown here, we can perform 3D printing and use this 3D printing model to perform some surgical operation simulation. We can further use the VR models to perform some VR-based surgical operation simulation shown here. This is the VR video, and this shows the surgeons perform simulation in the VR world. You can see that they hold 2 operators for the communication with the VR world. And finally, this the pictures in the surgery. You can see here this is the operative field. This is the operative field. It means the field or the picture that the surgeon can see during the surgery. And this is the one that's in the VR world. They're quite similar. And this one shows the final removed sinking myocardium. The yellow one is the sinking myocardium in the real world, and the red one, the maybe red one, is the sinking myocardium. They removed sinking myocardium in the surgery. They are quite similar, but we can see that some shape difference in the vertical. Maybe this is due to the myocardium can stretch or a little after they have been removed. Okay, this is the really last one. Clinical applications, telemetry of Austin septal disorder. Oh, sorry, this is atrial septal defect, ASD. This we are a hospital in another city in Guangdong, which is not our hospital. They have received a patient with ASD, as you show here. There's a hole between the left atrium and the right atrium. Actually, this is not a very serious congenital heart disease, but the patient was 69 years old, and she has suffered from the disease for 69 years, and the condition becomes worse because of the ASD and heart failure exists. So it's not easy to translate. It's not easy for the disease, for the hospital to tackle the disease, to make the right treatment. So they contact our hospital to give some suggestions. So we think this is a quite good case for tiny mentoring. Tiny mentoring means our expert surgeon guides the less experienced surgeon to perform the surgery remotely, which means the expert surgeon can just stay in the hospital and do not go to, for example, another city which is more than 300 kilometers away. And what we do is to use AI and VR to create the surgical process. And this surgical process can then used to teach the surgeons in another city to perform the surgery. And this is the process of creating the video. First, we get the CT images of the patient from that hospital, and we then use the AI to construct the heart model and use the 3D printing to print the heart model, make some initial surgical planning, and then we also use VR to perform the surgical planning. The subfinger D shows some key fingers, some key frames in the VR content of surgical planning. For example, the infusion position, the incision position in right ventricle, the anatomy structures of the hole between the right atrium and the left atrium, and finally, the suture process to block the hole. This is the beginning position of the suture and the end position of the suture. And there are also some suture process to suture the hole. After suture, the hole will be blocked. And this one shows the video or the pictures in the real video, in the real surgery. Let's watch this very interesting video. This is a minimally invasive surgery, so the surgeon need to have three holes in the chest. So here just indicate the position of the three holes for the minimally invasive surgery. Generally, there are three holes. One for video and another, one for video and another two for operation. This is inner structures of the heart or the patient heart. The pulmonary veins, the pulmonary vessels, and the blue one is the entry, the right entry. This is right entry. The surgeon needs to cut this and perform the surgery. And this is the inner view of the heart, inner part of the heart. This hole. This hole between the right entry and the left entry. And the surgeons can check the anatomy structures in the rear video. This trabecular valves, inferior velar cava. This is the initial part for coronary artery, coronary veins. And we can check. Okay, there's a triangle arrows as shown here. This arrow is associated with the ECG flow. It's very sensitive arrow. So during the process, during the suture, the surgeons cannot touch this part. The suture cannot happen in this part. The superior velar cava. This is the left heart systems. Mitral valves, and this is the right pulmonary veins. I need to. This shows the beginning part of the suture. This is the suture process. The whole process is divided into two parts. Actually, I don't know why they do this, but anyway, this is good for the patient to block the hole. Okay, this is two pictures in this event, and the left one is the picture in our hospital, Guangdong Provincial People's Hospital, and the right one shows the surgery room in Guangzhou People's Hospital. You can see here there are just videos. In the surgery room, they can see the videos, and there are other parts of the video. There are several monitors, I think, in the surgery room, so they can talk and talk in real time. This research is reported by more than 30 medias. A very interesting work. So last, I will like to share some interesting experience in doing AI in hospitals. Maybe the time is all. Okay, I will make this as quick as possible to save your time for a lunch, maybe lunch or dinner. The first one is misdiagnosis. You know, when I do the research for the diagnosis of congenital heart disease, I have learned how to make the right diagnosis of congenital heart disease for 2 weeks. I will work like this to make the diagnosis of congenital heart disease based on the CT images. And first I will not see the results, the final diagnosis in the report, and I need to make the diagnosis by myself, and then I will check whether I make the right diagnosis. And in this way, I roughly know how to make the diagnosis based on CT images for congenital heart disease. And interesting, I think I will never use this in real life. But someday a friend come to me and ask whether I can make sure whether diagnosis of congenital heart disease from another hospital is right or not. I just regard it as a joke first, and I performed the diagnosis, and then I found that the report from another hospital was wrong. But I'm not that sure at that time, so I asked another radiologist to check it again. And finally, we found that the diagnosis is not complete, which means there's a missed diagnosis. But the missed diagnosis is a very critical one. So there was some other following story between that friend and the hospital, which is a very shocking case for me, maybe. But anyway, from this case, I come to learn that the missed diagnosis is so common in clinical practice. There are many reasons for that. But from this story, I come to learn that AI may help them to reduce such kind of situations. Second, second is about it's the first time that I saw a real beating heart. I have attended several open heart surgeries. Open heart means that the throat needs to be opened, and you can see at least you can see part of the patient's heart. And first time I saw a real beating heart, I was astonished. The size of the heart will change periodically, but at the same time, the heart will rotate to some real angle. Will rotate. The size, not the size, but also their angle will change periodically. So it's very interesting, and yeah, it's very interesting during the research. The third story is about ethics. I have ever received some email from a student who is asking me that why is there only one normal case in the public data set? Can you share more normal case with me? I can't realize that. Oh, we can't. Sorry, we can't, because we cannot let healthy health people to perform the CT examination without no reason. We cannot do that because of ethics. Another story is about ethics. About ethics is a discussion from another friend who asked me that why is the details of coronary arteries is not labeled or captured in the CT dataset. You know, I have published a CT dataset about coronary artery segmentation. I have discussed this with physicians, and they told me that first they perform CT examinations for patients. The main purpose is to make the right diagnosis, which means we don't need to a very high-end CT with a lot of contrast agent and a dose to extract all the details of coronary arteries. Even if the coronary at the thin part, the details of the coronary vessels are blocked, it will have very less influence in the whole heart's function. So there's no need to do that. And when you will do that, there are much more contrast agent and dose that we need to inject it into the people's body, which will introduce some bad injuries. So because of ethics, there are a lot of constraints in the current clinical practice. And for example, in this case, there's no detailed detailed vessel structures or coronary artery vessels in CT images. There's no need to do that, and it will introduce harm to the people. And the fourth one I would like to share is that how doctors view AI. And actually they are quite anxiety they have a lot of anxiety about AI. And they ask me a lot, will we be replaced by AI in the future? I just answer, no, of course not, because we are humans. Patients need humans to talk to them, not the machine. But in the future, physicians who can use AI for their work can replace the one that cannot use AI in their work. Lastly, I would like to share with some interesting knowledge here, risk factors of cardiovascular diseases. Basically, there are several risk factors as shown here: smoking, alcohol, unhealthy food, high cholesterol, stress, diabetes, and obesity. Genetics and aging, cannot be changed for us, but we can pay more attention to the other parts shown here, especially for the unhealthy food, which account for 10 million CVD deaths worldwide. And for researchers, we may need to consider the stress, how to tackle it effectively. Maybe we can have more physical exercise. Anyway, take care of your heart and cardiovascular systems. So let's have a very brief summarization of my works. With a special focus of AI for cardiovascular diseases, there are 4 aspects in our lab. And we have published more than 10 data sets in CARCO, and we hope to make some contribution to the research about cardiovascular disease treatment and diagnosis. And that's all on my talk. Please feel free to check more about me on my personal website, and thank you.
Okay, thank you, Professor. So, Professor, you have introduced a lot of knowledge to us about the cardio disease diagnosis, treatment, and navigation, and also, Professor, you have given us knowledge how to keep our healthy life for our cardiac. So anyone who have question, you can unmute your microphone, or you can just type your question in the chat room box. So please, it's a Q&A time. So anyone have a question, you can just unmute your microphone, just speak. Or also you can type your question in the chat room box.
Hello, Professor Xu.
Hi.
I think your talking is brilliant, and I want to ask that you and your team have labeled substantial amount of data, and how this label process conducted? Is that done by using AI for course segmentation first and followed by manual refinement, or you have other more efficient methods?
Really, thank you for asking. Yeah, we have tried to, this depends on the capability of AI, actually. First, I would like to show that the labeling process is performed by several assistants. First, they are trained to, anyway, the whole process is manual. And we usually have to perform the labeling in 2 stages. First, several assistant will perform the label, and then we ask an expert to check the labeling to find if there are some cases that with some errors, the assistant will recheck or relabel it again. So basically, the whole process is manually performed. There's no AI involved because the reason is that if the AI capability is not strong enough, the segmentation result is not that good, and if the assistant performs the labeling check and refinement based on the AI produced results, it may take more time than just
Okay.
using just manually do it. Yeah.
Oh, I see that. And since you have so many data now that the foundation models are extremely popular, and with you and your team having so many data sets, is there any plan to train a cardiac specific foundation model for segmentation or diagnosis?
Of course, yeah, I believe it is a trend. It is the future. But for cardiovascular diseases or for many diseases, the data is not enough for effective training, uh, especially for some rare diseases. In
Oh,
our case, in our situation, we plan to use the echocardiography or ultrasound video to train the large language model. But for other cases, the data is obviously not enough for effective training or refinement or retraining. Yeah, because ultrasound videos in our center there are more than 200,000 videos per year. That's with this scale of data, we may consider to retrain or large language model for for research. Otherwise, we will not consider it.
okay, I see that.
Oh,
I have
thank
another
you for
question. Can I?
Yeah, please.
Okay, that on the main page 47, maybe I mean
Okay.
that during the surgical navigation, are these the anatomical structures obtained? Is that from a pre-operative CT scan? The data
Sorry, sir, 42,
47, maybe.
47. So can you see my screen?
no,
No? Okay, I
No,
just
no, you
maybe
can.
one moment. Yeah.
Uh,
that's fine.
30, 47. So
Yeah,
can you see? Okay,
yes,
47. Mm-hmm.
yes. And my question is that during the surgical navigation, are the anatomical structures obtained from CT, right? And the
You mean
CT
the
data,
mm-hmm.
and the CT data is obtained before the surgical, right?
Yeah.
And how is the registration achieved between the pre-operative CT data and the actual position during the surgical? How do you achieve the registration?
Registration. Okay. Uh, Actually, there's no registration process in this clinical application. We just extract or segment the patient's heart before surgery and show this model, so the segmentation results using mixed reality glasses for the surgeons. There's no
Oh,
registration. Yeah, they just check. The surgeons just check the segmentation models, segmentation results, and the field or the scene or the heart model they viewed during the surgery. They just check it. That's
okay.
that's no registration during the process. Yeah.
Okay. Thank you for your answer.
Yeah. Thank you. Yeah, it's okay.
Thank you for such interesting talk. I also for the data set I Professor, I also we have hosted a KL challenge in Mikai. So maybe next year we can get some data set from you in institute and to join the KL challenge if possible.
Of course, my pleasure. Yeah. To
Yeah, we are like a data set. So anyone who have question, you can just unmute your microphone.
Hello, Prof. Xu. Thanks for a very nice talk and also interesting presentation. I'm a student work on the pacemaker in the cardiovascular area. So I would like to ask some questions about if have you like faced with some patients whose image like MRI image or the CT image like they have embedded pacemaker inside, so maybe it will make the image like opaque or less clear. And after if that in that condition, how do you solve this question and to do the segmentation or also the following progress?
You mean some patient where some mental made diseases, so they cannot perform CT
Maybe they
examination?
can perform, but there will be some artifacts in the image. But
Oh, yeah.
but they also can be used for like AI segmentation. As I know, like some professor also do something about the artifacts.
Yeah.
So I just would like to ask whether you have some experience in this and how you solve these kind of question and problems. Yeah.
Okay, so first I do have very little experience in this topic. We call it the noising of CT images. There are many other noise in CT images. And the second one is that we can use the second is that it is really a very hot topic to perform denoising or for city image, not only for the noise you mentioned, but also there are the trend that many patients would like to perform low dose CT examination, and there are a lot of noise in low dose CT. So I think it is ongoing and hot topic in this field. Yeah, not only for the denoising of the mental the devices, but also for the future trend of using low dose CTs.
Ah, okay, get it. Thank you so much.
Thank you for the question.
Hey, Professor Xu,
So
may I ask a question?
Yeah, please.
Yeah, so when you mentioned the clinical application of the HCM, so you mentioned that the HCM will result in the change of the electrical propagation due to the thick muscle. So I wondering, ask for the HCM patient, what's the routine data you will collect? I see you collect things like 3D CT. So whether you will collect the ECG and other data set, and do you have any like follow-up data about whether this patient is dead because of the sudden cardiac death?
Yeah, if the patient have sudden death, will not have any data of it. But for ECG is commonly used for the diagnosis or for the initial diagnosis of HCM.
Okay.
Yeah, and we should have it, but we didn't connect it yet now. And for the follow-up data, for such kind of patient, follow-up is usually performed. So we should have that kind of data, but we need to contact the expert in the clinical side for this data. I think we have it, yeah, ECG and follow-up data.
Okay, thank you. So is it that you will do the segmentation and decide which area you will cut off to make the muscle like more normal instead of thinner? Is that correct? And how did you decide what's the area to be cut off during the surgery?
Just as shown here, can you see my screen? So
Yeah.
the right part shows the labeling rules for the C-kingdom myocardium during the surgery. So basically, in clinical practice, it is some kind of experience. They have just they have this as common guidance for the surgery, and that kind of guidance or the rules of the C-kingdom myocardium will and should be changed in the future. But currently, they are the common sense for the surgeons, as shown here the rules. They have a very strict rules for the thinking myocardium.
Okay. Okay, got you. Thank you so much. Thank you.
Thanks, Lei. So anyone who have a question? Okay, I think it's time. It's enough time for the Q&A section. So thank you, Professor Xu. Thank you again for such a great talk. It was really interesting to learn such so many AI technologies for heart care. So all of one, let's thank again to Professor Xu for his wonderful presentation. And I also show my big thanks to all of you for joining us today. So please stay in touch with us. Thank you again for coming. We hope to see you next time.
Thank you for being here.
Thank you, Professor Xu. So I think it's lunchtime in Germany.
Yeah, it's okay. I usually have a very late lunch.
It's dinner time in China.
Okay, enjoy your dinner.
Have you ever have a lunch? So this is the end of this meeting. So everyone, see you next time. Thank you, Professor.
Thank you.
Mhm.